কথা শুনে আমার মনটা আবেগ আক্রান্ত হয়ে গেল। থ্যাংক ইউ ভেরি মাচ নিম্মি। আসলে আমি নিম্মি যেরকম করে বললে ব্যাপারটা আসলে সেরকম কিছু না। আমি ঢাকা মেডিকেলে অ্যানেস্থেশিয়ার ছাত্র ছিলাম, পরে অ্যাপোলো হাসপাতালে এফসিপিএস এর অবশিষ্ট ট্রেনিং টুকুন করার সুযোগ হয়েছে ইকবাল স্যার এবং লুৎফুল আজিজ স্যার, আজহার স্যার, জাহাঙ্গীর স্যার ওনাদের আন্ডারে। এটাই হচ্ছে সবচেয়ে বড় অ্যাচিভমেন্ট ছিল। তারপরে এখানে আসার বাকি সবকিছু এটা জাস্ট একটা সিকোয়েন্স অফ ইভেন্টস, নাথিং মোর দ্যান দ্যাট। So those who have attended sessions with me in the past know that we try to speak English in this session. So I'll try that, and I hope all the participants, all the students will try to use English as the language of instruction in this course as well. So what we need to know, what we are trying to do today is not sharing any heavy knowledge, okay? So let's make it very clear. So we shall just discuss some simple tips of preoperative assessment and perioperative care of patients in their surgical journey. Okay, so we shall not discuss anything really heavy in here. What we are trying to start with is can everyone see my screen?
Not yet, no.
Sorry, I didn't get it. Can everyone see my screen?
No, not yet.
No?
No, not yet.
Sorry. Okay. What about now? Can we see
Yeah,
it
it's starting. Yes, it's starting.
Great, amazing.
Yep, you can see that.
Great. Great. So yeah, I think it's there. Right. So we don't have to define what high risk anesthesia is. I mean, it's kind of self-explanatory. So anyone who is a complex patient going through a complex anesthetic and surgical procedure will have a high risk anesthesia. So high risk anesthesia, of course, needs a collaborative effort, a multidisciplinary effort. So all the aspects of their surgical care is organized and maintained and performed in a very organized way. Okay, so it of course attempts to quantify the risk of a specific procedure for a specific patient. So that's the first goal we have today, to do some form of risk stratification. Every anesthesia will have some risks involved, but of course, some patients will be at the lower stratum of the risk, and some will be at a higher stratum of the risk group. So preoperatively, we need to do some form of risk stratification for every patient we anesthetize. And of course, it will be more relevant, more important for high-risk patients. Risk stratification is an essential process for shared decision-making and informed consent taking. So if you want to discuss the risks and benefits of any anesthetic procedure and any surgical procedure with a patient, you have to give them related information, related statistics. Otherwise, if the patient doesn't have enough,
তুমি কি স্লাইড দেখাচ্ছ?
জি স্লাইড দেখা যাচ্ছে না স্যার?
না, আমরা তো ফার্স্ট পেজটায় বসে আছি
আমরা
এখনো।
পেজটাতেই আছি, এখনো পর্যন্ত স্লাইড আসেনি। আমরা ভেবেছি দ্যাটস জাস্ট
স্লাইড আসেনি, আমরা জাস্ট তোমার এই
অনলাইন টিচিং 2020
সূচিপত্রতে বসে আছি।
আমার এখানে আসছে ইউ আর স্ক্রিন শেয়ারিং।
এই
কিন্তু আরেকবার করো।
স্ক্রিনটাতেই হচ্ছে গিয়ে স্লাইডস গুলো আসছে না, তো এটা শুরু হয়েছে কিনা আমরা বুঝতে পারছি না।
সরি, আচ্ছা আবার স্ক্রিন শেয়ার করি। স্ক্রিন শেয়ার, অনলাইন টিচিং।
আবারও সূচিপত্র আসছে। তুমি খুলে নাও আগে, পাওয়ার পয়েন্টটা খুলে নিয়ে তারপরে শেয়ার করো।
এখন কি আসছে? এখন কি স্লাইডটা আসছে?
না, not yet.
আচ্ছা, তাহলে স্টপ শেয়ার করলাম।
তুমি ওপেন করে নাও তোমার কম্পিউটারে আগে।
কম্পিউটারে তো এখন ওপেন আছে।
স্লাইড শেয়ারে দিলে তোমার কি শেয়ার করতে চাও সেটা আসলে তুমি স্লাইড গুলো দিয়ে দিও।
আবার স্ক্রিন শেয়ারে গেলাম। এখন আসছে?
স্ক্রিনটা the screen is yes exactly
এখন আসছে, তুমি ই করো।
but I think in that's
রিমোটে
the
যাও।
এখন আসছে?
yes
এখন স্লাইড দেখা যাচ্ছে?
তুমি স্লাইড শোতে যাও, শোতে হ্যাঁ পারফেক্ট,
এখন দেখা যাচ্ছে।
পারফেক্ট,
স্লাইড শোতে আছি স্যার আমি।
হ্যাঁ পারফেক্ট, ঠিক আছে।
Right. I'm very sorry for the interruption. I'm extremely poor in technology. My son normally handles all these things for me. He's of course in his school now, so I'm on my own. I'm extremely sorry for the interruption, but hopefully we'll be fine from now onwards. So why do you need risk stratification? Number one, so that we can give our patients adequate information and get adequate informed consent. Number two, this will allow us the opportunity for preoperative optimization of any comorbidity that they might have. At the same time, it will give us a golden opportunity to do any sort of lifestyle and behavioral changes in the patients, those are going into the surgical pathways. So how do we do the risk stratification? Oh, sorry, before that, what is the importance of risk stratification then? So these are the things for FCPS and MD final students. I was told that the exam pattern will change soon, like the FCPS exam pattern particularly will go into the same pattern of FRCA written. The questions like CRQ will be introduced. In questions like CRQ, you can easily be asked, what are the importance of risk stratification in patients going through high-risk anesthesia? So there are basically three importance that you need to enumerate. Number one, for informed consent. Number two, accurate clinical decision-making. So you can take the correct decision for the correct patient. What will be your anesthetic technique and what should be the surgical technique? And number three, benchmarking your performance. That means benchmarking your performance against a set standard. Now, how do we do risk stratification? There are basically three ways you could use. Number one, functional assessment. Number two, risk prediction model. And number three, risk scoring systems. All three together actually give you the whole spectrum of risk stratification. Just one of those is not enough. Out of these three, the first one, functional assessment, that bit we do in our day-to-day practice. But I think sometimes the other two, risk prediction models and risk scoring systems, are sometimes left alone or not adequately elaborated or highlighted. Functional assessment, as I said, we do in our everyday practice. So the easiest or most crude thing we do is we ask the patient, how much of exercise can you do? The commonest question we ask is how many flights of stairs you can walk up. It's a good question. This gives a crude idea of their functional reserve. However, we have to keep it in mind that this is actually confounded by many other factors. Many patients will be able to climb up 2 flights of stairs, but in between they will stop 10 times. They will be breathless. Many patients will not be able to climb up stairs, not because their heart is weak, but because they have got significant pain in their knees and hips. So this is good, but not the best. But by asking those questions about their functional reserve, we basically want to determine their metabolic equivalent. So as we know, 1 MET is roughly 3.5 ml per kg body weight per minute of oxygen consumption. So this is the resting oxygen consumption that someone is sitting down or lying down, not doing anything else. They will roughly consume that much of oxygen every minute. So we conventionally say that you need at least 4 MET of oxygen consumption to be able to go through a significant stress response of anesthesia and surgery. But as I said, this is a very crude way of assessment. Duke Activity Status Index, not really used these days that much. It was a questionnaire-based assessment pathway. So there will be some questions, you ask the questions, and that will reflect the patient's activity of daily living. Exercise tolerance test, ETT with Bruce protocol. I'm not sure we use it frequently these days, possibly a bit outdated. Incremental shuttle walk test, again, was popular at some point, but not really relevant anymore. The gold standard these days is cardiopulmonary exercise testing. I'm sure this is not a very easily accessible device, easily accessible equipment in our setup in Bangladesh. However, as I said, as a FCPS and MD finalist student, we have to have a basic idea of how a cardiopulmonary exercise testing works. So it's a complex machine. So there will be a bike along with a computer. The bike is something you will be paddling on, and that will be connected to a central computer with all sorts of ECG monitorings, blood pressure monitorings, SpO2 monitorings, and respiratory gases monitoring. What do we find from there? We basically find 2 parameters that you need to know. If there is a short note on cardiopulmonary exercise testing on an exam, so that you can write a few lines and reassure the examiner that you know what you are talking about. We try to find 2 basic parameters. Number 1, their anaerobic threshold, AT. So anaerobic threshold means when you're exercising, at some point, your aerobic oxygen will not be enough to supply your demand. So your body will try to top up with anaerobic pathway. When does it occur? It doesn't occur at the end of your capacity. Roughly what we have seen, halfway through the test, your anaerobic pathway actually gets activated and lactate generates and you get oxygen from that. So a cutoff for anaerobic threshold is roughly around 11 ml per kg per minute of oxygen consumption. About that much of, when you have consumed about that much of oxygen, you will have your anaerobic threshold appear. That means you are generating lactate. As I said, it doesn't mean your capacity has exhausted. However, this is a very important marker. Your anaerobic threshold roughly correlates with the risk of mortality during a high-risk anesthesia. Okay, so anyone who is really fit and well, like a trained athlete, will have an anaerobic threshold way higher than 11 ml per kg per minute. Then the next important parameter is VO2 max or VO2 peak. That is your peak oxygen consumption. This is somewhere you will stop the test. So you will stop biking, you will stop pedaling. That means you cannot do it anymore. You have reached your capacity. This is of course age and sex dependent. So young men will have a very high VO2 peak and elderly female will have quite low VO2 peak. However, there is a cutoff, which is 15 ml per kg per minute. So now if you multiply 3.5 by 4, so 3.5 multiplied by 4 is roughly around 14 or 15, isn't that? So I think this is where the whole idea of 4MET came from. So if you have a VO2 peak or VO2 max of 15 ml per kg per minute, that means you are relatively safe for anesthesia. And VO2 max or VO2 peak more or less correlates with the surgical or anesthetic complications in the period. Someone might have their microphone on, they can mute themselves if possible. Great. So what are we discussing? Just to recap, if anyone has joined a bit late, we are discussing preoperative assessment today. In the preoperative assessment, we said risk stratification is the underlying philosophy of preoperative assessment. Risk stratification is really important, and there are 3 methods of risk stratification. So far, we have just discussed the first method, functional assessment, which is the first method and most important method as well. The next 2 methods are risk prediction model and risk scoring system. So risk prediction model, normally we don't do, the surgeons do. As I said at the beginning of the discussion, that care of high-risk anesthesia, care of patients undergoing high-risk anesthesia is a multidisciplinary approach. Okay? You cannot do it yourself on your own. Okay? Surgeons have got a very important role to play here. So you have done your functional assessment. Now surgeons will normally do some risk prediction model because they are operating onto the patients. Okay? So they have to calculate a risk as well for their patient. For example, I'm sure you have heard of Euro scoring system. Cardiac surgeons do that. In general surgery, we use POSUM. So POSUM is in the new format of exam for FCPS student, for CRQ kind of exam. I think these are the things you need to pick up quickly. POSUM stands for Physiology and Operative Severity Score for enumeration of mortality. Okay, so this U should have been capital U. So this U goes into here. So physiology and operative severity score for enumeration of mortality. Basically, you are taking the patient's physiological variables into consideration. At the same time, you are taking the operative severity as well into consideration. And adding them up, you are finding the mortality of your patients. So P postmortem is a variant of postmortem. P stands for Portsmouth. Portsmouth is a city in the southwest coast of England. So they basically invented it. So we use it countrywide now. So P postmortem is the scoring, is the prediction model we use for our NELA. NELA stands for National Emergency Laparotomy or Audit. So basically, P postmortem is the risk prediction model we use for emergency laparotomies. And believe me, there's a very well validated risk prediction model. Okay, so surgeons and anesthetists combinedly do it. So that is an easy to use software. You put the patient physiology data and the operative severity score data, and then the software gives you a score and gives you a score and based on that mortality. Okay, and that mortality is a real chance of your patient dying in an emergency laparotomy. So these are crucial things you can find out in the perioperative period. Then finally, so recapitulating again, we are still within risk stratification system. We have discussed functional assessment, we have discussed risk prediction model, and finally, there are some risk scoring systems. Okay? So this is something you do, you as an anesthetist do. You have done your functional assessment, leave the risk prediction model with the surgeons. Now as an anesthetist, you find out some sort of risk scoring for your patient before you anesthetize them. Many of these risk scoring systems you already know, like ASA, NYHA. These are kind of very primitive kind of risk scoring systems. Say, for example, ASA is always plus or minus 2. Any patient, you say ASA 2, I can say ASA 4. It's just the way we look at that patient and look at their physiology. This is not really anything very well validated these days. So after that, Goldman's risk stratification system came, was not very popular. ACC AHA guideline, there are two pathways of that, clinical and surgical pathways. That's still popular on the other side of Atlantic, not in here. Detskis modified cardiac risk index was popular at some point, but now, over the last 2 decades, we are using Lee's revised cardiac risk index. This is really a well-validated risk scoring system. You can find out real risk of mortality and serious morbidity of your patient undergoing a high-risk anesthesia. What are the variables? Very simple 6 variables. Number 1, history of ischemic heart disease, history of chronic heart failure, history of cerebrovascular disease, diabetes mellitus with perioperative insulin use. So type 2 diabetes who never use insulin, even in the perioperative period, will not be included here. CKD with a creatinine of more than 170. I beg your pardon if you don't use this unit, but you can always convert the unit. And undergoing any intraperitoneal or intrathoracic surgery. You can see operations like neurosurgery are not validated to go through Lee's revised cardiac index. This is mainly for major laparotomies and major thoracotomy kind of operations. The only thing that I tend to criticize on Lee's revised cardiac index is there is no variable of your respiratory system, as you can see. Sometimes you can appreciate actually some of the respiratory comorbidities can have significant impact on your perioperative outcome. That's not there. However, this is what this is. So this is a well-validated system. So if you have one of these predictors present, for example, your patient has got a history of ischemic heart disease, very common these days, isn't that? Your patient will have a percentage of chance of dying in operation. If they have 2 comorbidity out of these 6, I mean, there are 5 comorbidity and 1 procedure. If they have got 2 variables present out of 6, then they will have a significantly higher risk of dying or having a kind of fatal, or not fatal, I mean a serious problem in their perioperative journey. Let's look at the numbers. So if we have 0 predictor present, so like none of this present, a relatively fit and well patient undergoing a major operation, but not intraperitoneal or intrathoracic, they will have a 0.4% chance of cardiac death or non-fatal MI or non-fatal cardiac arrest. So it's self-explanatory. So if you have a fatal MI, that means you have died. So your chance of dying or chance of having a massive MI or a cardiac arrest, which you survived, didn't die. That kind of problem, the chance of that kind of problem happening is 0.4%, even if you did not have any of those predictors present. If you had 1 predictor present out of those 6, your chance of dying is 0.9%. 2 predictor present, 6.6%. So you can see there is a big jump here. 3 or more predictor present, your chance of dying is pretty solid, you see, 11%. That means 1 out of 10 patients will die. So I'm sure you have anesthetized patients who have got significant ischemic heart disease, history of CVD, history of CKD. It's very common, isn't that? So any patient who has got 3 or more comorbidity like that will have an 11% chance of either dying or having a serious, massive MI or a non-fatal cardiac arrest in their perioperative journey. So because now you know that your comorbidities, your coexisting diseases can have that kind of serious impact in your perioperative outcome. So this is your chance. So you try and optimize some of their comorbidities, okay? And the whole idea of optimization of their coexisting diseases is nowadays given in a new umbrella called prehabilitation. You must have heard of rehabilitation that we do after operation. Now we have data to believe that rehabilitation is possibly not the best approach in managing perioperative patients. You have to be proactive rather than reactive. So you have to have a plan of prehabilitation. Again, prehabilitation is a multimodal process involving surgeons, anesthetists, critical care specialists, your medical colleagues, cardiologists, orthogeriatricians, many more, physiotherapists, nutritionists, everyone in your hospital. So they can have a well-structured approach long before they have their operation. So what are the main components? So again, for students appearing in FCPS and MD exam, you can have a CRQ asking for what are the main components of your prehabilitation. Okay? Main 4 components I would say is structured exercise program, nutritional optimization, psychological intervention, and lifestyle changes. Okay, these things sound very simple, but believe me, these, when you bring them together, bring about a massive change in the perioperative outcome. They, on their own, on its own, is not very helpful. They will just give you marginal gain. So if you just do nutritional optimization, that will give you a bit of marginal gain. But when you put all of those things together, you will have a serious benefit. So I mean, elaborate discussion of all these things is way out of the scope of this discussion. So we'll just have a very quick overview of every component of this. Preoperative exercise. So even if you cannot do anything serious with your patient in preoperative assessment, ask them to do some simple exercise for at least 2 weeks before an operation. So when do you see your patient in pre-op clinic? If they have to have a elective operation, I mean, if you see a patient 1 day before operation, that doesn't have any value. If you manage to see an elective patient or semi-elective patient for 2, 3, 4 weeks before an operation, ask them to do some form of simple exercise, whatever exercise they fancy of, half an hour a day for at least 2 weeks. There is data to believe that an exercise program of as short as 2 weeks will reduce their morbidity, decrease length of stay and in hospital, and increase quality of life. But there are structured exercise programs these days, so exercise is looked at as if this is a medicine these days. So there are structured programs which we may have, if we have an opportunity, we'll discuss another day. Nutrition optimization, obviously, very, very important. And this has to be preventative rather than reactive. So you find someone going into the catabolic stress 3 days after operation, and then you do something, it doesn't make any sense at all. Okay? So if you have to do something, you have to do it before operation. So otherwise you will have muscle deconditioning, fatigue, impaired immunity, poor wound healing. Believe me, if you have a muscle deconditioning, all your respiratory muscles will be weaker and your postoperative ventilation will definitely be impaired. You will have a very high chance of developing a HAP or VAP, whatever. So this is a very simple sort of flow chart to find out if someone needs nutritional optimization. Anyone who has got a BMI of less than 20, 18.5 is possibly a bit old-fashioned, so I would ignore that. Maybe BMI of 20, anyone less than a BMI of 20, or anyone who has lost more than 10% weight over the last 6 months, or anyone who is eating less than 50% of normal. Check their albumin. If their albumin is less than 3 or less than 30, depending on your unit, they will need some form of nutritional optimization. Psychological intervention is very important, mainly because if you are very anxious and not ready to adhere to the program, then everything will be ruined. Whatever optimization program you give your patient, you will need active participation of your patient. Okay? So if your patient is not motivated enough, if they are psychologically withdrawn, all your efforts will fail. Lifestyle modification. So why this is important in perioperative period? We say perioperative period is a teachable moment, really teachable moment in a patient's life. Their heart is very soft. They are emotionally challenged before a major operation. So if you say something, if you say something to them in a nice way, they are more likely to take your advice. So this is the time they can possibly stop smoking and reduce alcohol consumption. As you know, 4 to 8 weeks of smoking cessation is helpful. However, abstinence of smoking even for 12 hours is beneficial. Now, so this is how the whole idea of prehabilitation works. Now, these are all the generic things, of course. Now you have to consider your individual systems, individual systemic comorbidity, how to optimize those. So all the systemic discussion is way out of the scope of discussion in this session. We'll just have a very quick overview and possibly just touch base with one system. Okay? So hypertension is a very common comorbidity. We'll talk a bit more, elaborate on it later. Diabetes, again, a serious comorbidity which will have very significant impact on your perioperative outcome. Anemia. So preoperative anemia, so up until 20 years ago, we didn't know that preoperative anemia or even mild anemia can have a really serious impact in your perioperative outcome. But since the ERAS pathway, the enhanced recovery program pathway evolved, since then we know even mild anemia or even axial or functional iron deficiency without iron deficiency anemia can have a major impact. So any patient who has got a preoperative hemoglobin level of 100, less than 130, irrespective of their age and sex, anyone who has got a preoperative hemoglobin of less than 130, they should ideally have a, if they are for elective surgery, I mean, they should ideally be classified into the group of anemia. I'm sure all the postgrad students by this time definitely know the morphological and etiological classification of anemia. So you need to class their anemia, and then if they are, if you define them as iron deficiency anemia, you check their iron profile, check their ferritin, and consider oral or IV iron transfusion before you proceed for your elective surgery. Again, the detailed discussion is out of the scope of today's topic. Frailty is something we have to talk about in short, okay? Again, for questions like CRQ, you can be asked about frailty. So let's not confuse frailty with age, because age is definitely not the sole predictor of frailty. Frailty can happen in younger people as well. Okay? So it has got, again, multifactorial. It's got biomedical, psychological, and social factors. And how do you modify frailty? So frailty is basically modified with your prehabilitation program. And as we said, prehabilitation is multifactorial, involving all this personnel from all these specialties. Then the stress response. So just to recap very quickly, we are discussing anesthesia for high-risk patients. We have briefly discussed how we stratify risk for our high-risk anesthesia, and then we are slowly finishing our pre-operative phase of management of high-risk patients. So we have briefly discussed their optimization, briefly gone through the systemic diseases which we may need to optimize. And now we are slowly moving into the intraoperative phase. So pre-operative is more or less done. Now into intraoperative phase we are moving into. In the intraoperative phase of high-risk patients, the most important thing to remember is the stress response to surgery. So one of our teachers in Bangladesh used to say, our body look at an operation as if we are exercising. So such a valuable statement that was, okay? When you have a massive operation, our body thinks we are doing a vigorous exercise, okay? So that is where the idea of stress response comes from. And the stress response starts even before the operation, but it possibly maximizes around day 3 post-op. Okay, so I'm sure at this stage all the postgrad students have a very clear idea of the different hormonal pathways that are involved in stress response. I'm sure you have gone through those in your first part exam of MD and FCPS. So you will have your sympathetic nervous system activated, which will activate your stress response. Then after operation, you will have your postoperative pain, which will also activate your stress response. When you have activated stress response, your heart will increase inotropy and chronotropy. And then at the same time, your vascular system will have increased systemic vascular resistance. And all this together will have increased blood pressure. At the same time, a crucial thing happens, and that is you will have another hormone activated that comes from your posterior pituitary or hypothalamus. That is your ADH, your vasopressin. Okay? When you have ADH active, when you have excessive ADH release, you will have platelet adherence, and then you will have thromboembolic complications, thromboembolic tendency. And that is the whole reason we give thromboprophylaxis for every surgical patient. What we didn't know up until only 15, 20 years ago is what is in the heart of all these stress response. Now we have got the answer, okay? This is a relatively new invention. So insulin resistance is the phenomenon which actually lies in the heart of all your stress response pathways. What happens is, as soon as your body gets into surgical stress, your body enters into a state of insulin resistance. That means the shift from an anabolic into a catabolic pathway, catabolic state. Okay, so that means insulin resistance essentially means your insulin will not work very well, so your blood pressure will rise. I'm sure all of you have seen in the perioperative period, even your non-diabetic patients will have a erratically high blood sugar. Most of the time we ignore it. We say, okay, they're not diabetic, it's fine, it will come down. But no, that's not true. Because now the new term is tossed called diabetes of injury. So when you have massive stress response, thus insulin resistance, thus hyperglycemia, you are basically now diabetic. I mean, this diabetes is not that diabetes, but this is still a form of diabetes called diabetes of injury. And believe me, there is data that hyperglycemia in non-diabetic patient is no less harmful than those in diabetic patients, sometimes even more harmful. So management of blood sugar is equally important in diabetic and non-diabetic patient in the perioperative period. So again, touching the base, the main idea is insulin resistance in the perioperative period. That gives you all the bad effects of stress response. And here comes the idea of carbohydrate loading. We are not going to elaborate this too much, just to give a very rough idea that if you give your patients, particularly your GI patients, a maltodextrin kind of polysaccharide as a clear drink, one dose the night before operation, another dose in the morning of operation, that will help reduce your insulin resistance and thus decrease your stress response. There is compounding data that carbohydrate loading does decrease your mortality and morbidity, decrease length of stay, and overall better outcome. Now, intraoperatively, what can we do? We can do all the good things. And from now onwards, we'll go very quickly because these are all the good things that we already know. What can you do to optimize your patient outcome in the intraoperative period? You can maintain normothermia, you can minimize blood transfusion. Now we know we have solid evidence now to say that blood transfusion is harmful. So avoid blood transfusion as much. I mean, you have to give blood if you have to, that's different, but avoid if you don't have to, and you know your blood transfusion threshold is, hemoglobin threshold is 7 or 70, whatever unit you use. Okay? Not in a bleeding patient, of course. If your patient is actively bleeding, that's different. But in a chronic anemic patient, your threshold for blood transfusion is 7 or 70 of hemoglobin. So guided fluid therapy, and finally enhanced recovery pathway. These are the things you need to know. Out of these, the only thing we'll discuss in very shortly is goal-directed therapy, goal-directed fluid therapy. Now we know that neither dehydration nor overhydration is good. And the way we looked at fluid therapy in the past has completely changed, okay? Now we tend not to give maintenance fluid for our patients. We rather try to give bolus fluids, okay? And bolus fluids with a goal in our head. One of the most sensitive goal is stroke volume variation, SVV. Stroke volume variation, I beg your pardon. Stroke volume variation is a very simple parameter to use. So if you just have a simple arterial line from your arterial line trace, so pulse wave contour, you can find out most of the modern monitors will give stroke volume variation or pulse pressure variation anyway. So pulse pressure variation and stroke volume variation are pretty much the same thing. You can change them alternatively, interchangeably, I mean. So, or if you wanted to use more advanced monitors like LITCO or esophageal Doppler, you will have better results, but the basic thing will be same. So if your stroke volume variation is less than 10%, that means your patient is optimized. They don't need further fluid therapy, further fluid bolus, I mean. If the stroke volume variation is more than 15%, they are almost certainly fluid depleted. They will be benefited from fluid therapy. If it is less than 10 to 15%, it's possibly equivocal. If you didn't want to use those techniques, you can still rely on the slightly older techniques like your CVO2 or lactate or even base access, I mean base deficit. These are still valid. Urine output is still a very valid marker of goal-directed fluid therapy. Postoperative. What do you do? Again, postoperative care of patients is again a multidisciplinary care. Everything is multidisciplinary. So you will again need proactive rather than reactive care. Critical care specialists will have a very important role in here. Pain management is possibly the main thing we need to elaborate or highlight in postoperative care. Pain management, as you know, should always has to be multimodal. So if you have a question in FCPS final on pain management, the first line you should write is multimodal approach. As soon as you have written that, your examiner will be reassured that you know what you are talking about. Okay? So what does multimodal mean? It essentially means you and surgeon both will have some role. So surgeon will do some local anesthetic blocks if they can, like rectus sheath block they can do in under direct vision, or simple local infiltration is very good for many different operations. You will do all sorts of peripheral nerve block, plexus block, whatever you can do, and you can safely do, I mean. You will try to use opioid sparing approaches. Okay? Too much of opioid is not good, as you know, and you will always use multiple drugs. IV paracetamol is kind of neglected, massively neglected in some parts of the world. Believe me, 1 gram of IV paracetamol has got a equivalent analgesic potency of 4 to 5 milligram of morphine. So use IV paracetamol if there is no contraindication, things like that. So all the drugs you use together to reduce the opioid requirement and thus improved patient outcome, decreased length of stay. To finish it very quickly, enhanced recovery after surgery, ERAS. So ERAS is not anything new. It's a 2 or 3 decades old pathway or concept. So it's again a multimodal package that has got preoperative, intraoperative, and postoperative segments. We have discussed all of this already. So enhanced recovery, I mean, the term itself is self-explanatory. You want to keep your patient for the least period of time in your hospital. So try to admit your patient on the morning of operation rather than the night before. So reduce preoperative fasting. There is evidence that prolonged fasting doesn't really help. Okay, so if you thought fasting of more than 6 hours will be more reassuring, that's wrong. Okay, so just 6 hours of fasting of solid food is good enough. Shorter fasting will have better outcome, but of course not less than 6 hours for solid food. Optimize hydration, carbohydrate loading if you can, and try to avoid bowel preparation if you can. So there is evidence that vigorous bowel preparation will actually have a bad outcome. In the intraoperative period, try to do minimally invasive operations. So minimally invasive means less cutting, less tissue damage, less stress response, clearly beneficial. Try to avoid tubes and drains as much as you can. Of course, use them if you have to use. Local regional techniques, like all sorts of peripheral nerve blocks as appropriate, normothermia, and postoperative nausea and vomiting prophylaxis. And post-op, rapid rehydration, planned and early mobilization, and most importantly, multimodal analgesia. So these all together will give you a complete model of care for your perioperative patients. So this is the end of the first phase of the discussion, if that is okay. I will give the microphone to the moderator now, if that is okay.
Thank you so much, sir, for this excellent talk on optimization and assessment of high-risk anesthesia. As an example, as much as I'm doing, and I don't have any more questions discussion, but I'll ask Sir to comment on this part of the session, and then we can move forward. Thank you again for this excellent presentation. Dr. Fairdous Bhai is here, and he's thanking the speaker for his excellent presentation as well. I'll ask others to unmute if they want to say something. Apu, you are unmuted. Sir, you are unmuted. You as well.
Iqbal sir, bolen.
Sir, over to you.
Thank you very much for asking. Although Rahman has been very strict about the students to communicate in English, I'm no longer a student in a real sense. Student anyway, but not the thing that he is really meaning. I will do Bangrezi as usual. So, Amar mone hoy je what Rahman has done is quite impressive to me. এবং ও এম করেছে FCPS কিংবা MD স্টুডেন্টসদের টিপস দেওয়ার জন্য এই লেকচারটা। The material he has been giving us is generally অধিকাংশ সবাই ছাড়া ভাবে পড়েছে, জানে, কিন্তু সাজানো নেই। এগুলোকে সাজিয়ে একটা সাজানো ডালি ও আপনাদের কাছে উপহার দিয়েছে। আমার বিশ্বাস এগুলো যথেষ্ট কাজের এবং কাজে লাগবে। তবে রিস্ক নিয়ে একটা কথা, সামান্য দুটো তিনটে কথা আমি বলি, কারণ আমরা ওইটাই প্রথম দিকে আমরা জানি যে পেশেন্টের রিস্ক কত। মানে আমি যদি একদম ডাউন টু আর্থ চলে যাই, তাহলে আমরা জানি যে patients will be asking, the surgeon will be asking, the anesthetist will be wondering how much is the risk associated with a particular surgery. Nice, Rahman is quite, I'm sure he's oriented with this thing.
There are
nice.
some internet issues.
আমি শুনতে পাচ্ছি না?
স্যার এখন শুনতে পাচ্ছি
স্যার।
ওকে, নাইস রিকমেন্ডেশনের মধ্যে আমরা যেমন জানি যে রিস্কের যে গ্রেডিং করা হয়, তো অ্যানেস্থেটিস্ট রিস্ক অ্যান্ড দ্য সার্জিক্যাল রিস্ক অ্যাজ ওয়েল, দুটোর গ্রেড আলাদা করে একসঙ্গে বিচার করা হয় যে হোয়াট দ্য কোর্স উইল বি। তো সুতরাং এখানে আমরা মনে করি যে when you are talking about risk, the stratification should be based on, and it is actually based on the anesthesiologist who is doing it. কারণ এটা রুগী অ্যানেস্থেটিস্টের কাছে একটা patient handling is risky. On the other hand, an efficient anesthetist will do it better. The surgeon, the procedure, lastly, of course, the facilities is very important. যে কোথায় কি facilities আছে, সুতরাং whether a particular surgery can be done here or it will be too risky to get it done there. এবং পেশেন্ট ইটসেলফ যে ও কিন্তু জেনারেলি পেশেন্টসের পরে কনসেন্ট্রেট করেছে যে আমাদের স্ট্র্যাটিফিকেশনটা অধিকাংশ বাই অ্যান্ড লার্জ পেশেন্টের পরে করা হয় স্ট্র্যাটিফিকেশন, এবং সেগুলো ভাগ করেছে আলাদা আলাদা ভাবে, হুইচ ইজ কোয়াইট ইন্টারেস্টিং। এবং আমরা জানি যে এর জন্য হাজারো স্কোরিং সিস্টেম এসছে, অধিকাংশই এলো গেল অবস্থাতে। ফাংশনাল অ্যাসেসমেন্টের ব্যাপারে হি হ্যাজ put a lot of thoughts, has given us a lot of information. Mostly আমরা কিছু জানি, আর কিছু হয়তো আমাদের নতুন সংযোজিত হলো। তবে সবকিছু যতগুলো টেস্ট বলুক না কেন, এভরিথিং শুড হ্যাভ আ সেন্সিটিভিটি অ্যান্ড স্পেসিফিসিটি। এই দুটো জিনিস খুব ইম্পর্টেন্ট, যে আমি যে টেস্টটা করি না কেন তার সেন্সিটিভিটি কি আছে আর স্পেসিফিসিটি কি আছে, এটা জানলে পরে আমাদের ওই টেস্টগুলোর ভ্যালিডিটি, যেটা বলছে বারবার, যে এটার ভেরিফিকেশন করতে সুবিধা এবং বুঝতে সুবিধা হয়। He has not gone a long way, but he has shown the path. যে পাথটা আমরা মনে হয় যে আমাদের young anesthetists can take, especially somebody who are preparing their examinations. তাদের জন্য অনেক গাইডলাইন্স আছে, অনেক টিপস আছে, সর্ট অফ বলবো আমি ট্রিক অফ দ্য ট্রেড নয়, টিপস যেগুলো করা উচিত, এবং ডুজ অ্যান্ড ডোন্টস থেকে বেশি ডুজের পরেও নজর করেছে বেশি আমাদের। তো আমি মনে করি যে ওভারঅল হি হ্যাজ গিভেন আস সামথিং এবং একটু নতুন ভাবে প্রেজেন্ট করেছে। যারা ছাত্র তাদের জন্য তো উপকার হবেই, এবং যে আমরা যারা বৃদ্ধ, যারা টাচে নেই বেশি দিন, বিশেষ করে আমি একেবারেই টাচে নেই, তো আমাদের জন্য এগুলো নতুন জ্ঞান আহরণ করা। তবে আমার মনে হয় যে অধিকাংশ ছাত্ররা ক্যান এঙ্গেজ themselves in lot of discussion, and Rahman will be, I'm sure he will be only too willing to respond accordingly. Thank you, Rahman, for doing a great job. It seems that you have done your homework, and it seems that you are quite willing to do more in future. And thanks others too for being very patient and listening to all this important material. And আমার মনে হয় যে I'm not signing off, but I think I can keep my mouth shut from now on. Thank you.
Thank you so much, sir. Ajay sir, if you'd like to comment on the session, would be great to have you.
At this page, academic discussion আমি আর সময় নিব না, 9:15 হয়ে গেছে। আমার মনে সেকেন্ড পেজ ইউ ক্যান গো স্ট্রেট ওয়ে।
একটু জাহাঙ্গীর ভাই কিছু বলেন না?
আমি বলবো না, পলাশের প্রেজেন্টেশনটা আমি খুব মনোযোগ দিয়ে শুনলাম। ইট ওয়াজ রিয়েলি নাইসলি প্রেজেন্টেড। তো যে জিনিসগুলো আছে, হ্যাঁ, এগুলো স্যার যেটা বললেন, ইকবাল স্যার, যে এই জিনিসগুলো সত্যি আমাদের যারা মানে এফসিপিএস বা এমডি যারা পরীক্ষা দিচ্ছে তাদের জন্য এই ওরিয়েন্টেড পড়ালেখা করা দরকার। এটা আমি বলবো। মানে আর সবচেয়ে বড় জিনিস যেটা ওর প্রেজেন্টেশনটাতে একটা ইনসাইট দরকার। আমরা যাই পড়ালেখা করি, আমি যে জিনিসটাতে সবসময় বলি, ইনসাইট দরকার। আমি কি করছি, কেন করছি। এই যে মানে ও একটা জিনিস বলছে যে পেশেন্টের সাথে কাউন্সেলিং এর সময় একটা ইনফর্মড কনসেন্ট। যদি পেশেন্টকে আমার ইনফরমেশন গুলো দিতে হয়, তাহলে আমাকে নিজেকে আগে জানতে হবে, এবং নিজে জানার জন্য আমরা কিন্তু আরেকটা জিনিস আমি বলি যে ও যে কথাগুলো স্ট্রেস দিল, সেই স্ট্রেসটা হচ্ছে অন ফাংশনাল অ্যাসেসমেন্ট। আমরা অনেক ক্ষেত্রেই আমি বলবো বেশিরভাগ অ্যানেস্থেটিস্ট আমাদের দেশের আমরা যেটা করি সেটা হচ্ছে অ্যানাটমিক্যাল বা নন ফাংশনাল অ্যাসেসমেন্টটা করি। যেমন আমি একটা কথা বলি, একটা চেস্ট এক্সরেতে একটা সার্কামস্ক্রাইবড একটা শ্যাডো পাওয়া গেল অ্যাপেক্সে, মেবি এটার একটা ইমপ্লিকেশন আছে, এটা ডায়াগনোসিস হওয়া দরকার, এটা কি হতে পারে। কিন্তু আমাদের অনেক অ্যানেস্থেটিস্ট বলে যে না, এটা আপনি এই করে নিয়ে আসেন, রিপোর্টিং করায় নিয়ে আসেন, এই করেন সেই করেন। কিন্তু আমার অ্যাকচুয়ালি যে জিনিসটা দেখা দরকার, এই যে শ্যাডো যেটা আছে, ইজ ইট এফেক্টিং হিজ পালমোনারি ফাংশন। যদি পালমোনারি ফাংশন অ্যাসেসমেন্ট আমি করি, তাহলে যেমন একটা সিম্পল একটা টেস্ট আমাদের এখানে বেডসাইডে করা যায়, ব্রেথ হোল্ডিং, কাফিং পাওয়ার, এই যে স্পুটাম ক্লিয়ারেন্সের জন্য আমার যেসব টেস্টগুলো লাগবে, ব্রিদিং এক্সারসাইজের কথা পরে আসি আমি যদি আগে ফাংশনাল অ্যাসেসমেন্টটা যদি না করতে পারি, তাহলে আমার কোনো লাভ নাই। কিন্তু শুধু একটা এক্সরে আমার দেখলে হবে না, তার ফাংশনাল অ্যাসেসমেন্টটা করা দরকার। সিমিলারলি একটা ইসিজি দেখে আমি বলে দিলাম যে হ্যাঁ, তার মধ্যে তার ইসকেমিয়া আছে, কিন্তু তার ফাংশনালি হার্ট কতটা এফেক্টেড, সেই জিনিসগুলো কিন্তু আমাদের জানা দরকার। সেটা আমরা কিন্তু খুব বেশি একটা, আমাদের অ্যানেস্থেটিস্টরা আমরা কিন্তু সেই জিনিসটাকে খুব বেশি একটা ইভ্যালুয়েট করার চেষ্টা করি না, ফাংশনাল অ্যাসপেক্টস। তো পলাশ যে জিনিসগুলো বললো যে ফাংশনাল, এই প্রত্যেকটাই মানে যে স্কোরিং সিস্টেম যেগুলো আছে, রিস্ক অ্যাসেসমেন্ট, রিস্ক স্ট্র্যাটিফিকেশন, সবগুলো কিন্তু ফাংশনাল বেসিসে। তো আমি যে জিনিসটা বলবো যে আমাদের অ্যানেস্থেটিস্টদের উচিত এই ফাংশনাল জিনিসগুলোর প্রতি বেশি স্ট্রেস দেওয়া, ওই শুধু অ্যানাটমিক্যাল এন্টিটি গুলো না দেখে ফাংশনাল অ্যাসেসমেন্ট ইজ মোর ইম্পর্টেন্ট। এবং এই যে স্কোরিং, যে নতুন সিস্টেমে যে স্কোরিং যেগুলো আসছে, সবগুলো কিন্তু ফাংশনাল অ্যাসেসমেন্টের উপরে বেস করে। আর আমি আরেকটা কথা যেটা বলতে চাচ্ছিলাম, পেশেন্টের সাথে যদি আমাকে একটা ইনফর্ম কনসেন্ট নিয়ে যদি কথা বলতে হয়, তার কাছ থেকে যদি ইনফর্ম কনসেন্টটা নিতে হয়, তাহলে আমাকে কিন্তু তার ফুল একটা কাউন্সেলিং দরকার। আমরা কিন্তু এই জিনিসটা কিন্তু একেবারেই কিন্তু মানে ইন জেনারেল আমি বলবো বাংলাদেশে এটা অ্যাবসেন্ট, আর আমাদের হাসপাতালে যেটুকু আছে সেটাও কিন্তু ইনসাফিসিয়েন্ট আমি বলবো। কারণ আমরা কিন্তু বলি না, আমাদের প্রত্যেকটা একটা পেশেন্টের যদি মানে দুটো কোমরবিডিটি থাকে, একটা কার্ডিয়াক অথবা একটা পালমোনারি, তাহলে কার্ডিয়াকটার জন্য তার কতটুকু রিস্ক ইনভলভ, পালমোনারিটার জন্য কতটুকু রিস্ক ইনভলভ, এবং কেন, তার অপশনস কি আছে, এগুলো কিন্তু আমরা বলি না। আমি সেই জন্য বলবো এই পেশেন্ট সম্বন্ধে যতটা সম্ভব আমাদেরকে জানা দরকার, জানতে হবে, ফাংশনাল অ্যাসেসমেন্ট করতে হবে, এবং তারপরে পেশেন্টের সাথে আমাকে কথা বলতে হবে, এবং তখন আমি রিস্ক ফ্যাক্টর গুলো বলবো যে কি কি আছে। তো ডক্টর পলাশ, ভেরি নাইস, ইট ওয়াজ আ নাইস প্রেজেন্টেশন আমি বলবো। থ্যাংক ইউ ভেরি মাচ।
Thank you, sir, for your invaluable input. So we can move on the second phase, if that's okay.
Yeah. So of course we cannot discuss all the systems, how we pre-optimize all the systems today. What we can do a trick. So again, Bonna, I may have a bit of problem in screen sharing again, but I'll try that doesn't happen again. Can you see my screen now, Bonna?
I can see the online teaching 2020, that bit in the folder section, but the PowerPoint presentation hasn't started yet.
Okay, just bear with me a second then.
That's absolutely fine.
Now, anything now?
No, it's the same. Yeah, we can see that now. Assessment
Can you see the slides now?
Yes, we can.
Great. So just bear with me. I'll go into the, yeah. So I thought we will very briefly discuss just a small part of optimization of one system today. Cardiovascular system. Why cardiovascular system today? Because today is the World Heart Day. Did anyone know? Today is
It's 29th
World Heart Day. So if you haven't given away your heart to anyone yet, this is the last opportunity. Few hours left. You better leave the webinar and give the heart away. This is a good opportunity. If you have already given, then let's continue with the webinar. Cardiovascular diseases, how to optimize them. So it's hard to live with a broken heart. Basically, you will die if you have a broken heart, okay? So we need to know what are the major problems that affects high-risk anesthesia from cardiovascular system. The main things are, of course, hypertension will be at the top of the list, ischemic heart disease, heart failure, valvular heart disease, infective endocarditis, cardiomyopathy, and congenital heart disease. So today we will very briefly see how hypertension can be optimized in the perioperative period. So very briefly, we know the stage of hypertension. So anyone who has got a blood pressure of less than 140/90, they are normotensive. So stage 1, 2, 3, 4, these are nothing to elaborate too much. So 140 to 159 is stage 1, and then so on. Just for the students, a small thing in this stage 3, the gap is 30. So in stage 1, the gap is 20. The stage 2 gap is 20. In stage 3, the gap is 180 to 209. And then in stage 4, more than equal to 210 in systolic. How do you measure blood pressure? I'm not going to elaborate this, but the thing we need to keep in mind is you need a relaxed patient and standardized equipment, standardized environment to have a correct blood pressure reading. How do you diagnose hypertension? A normotensive patient, as we said, will have a blood pressure of less than 140/90. However, in your preoperative clinic, if you have found a blood pressure of 140/90 or higher, you don't tag them as hypertensive. You wait, you take 2 more readings. Each reading at least 1 minute apart. Actually, it should be 5 to 10 minutes apart. And then you discard the first reading and take the lower of the last two readings as their blood pressure. And then if the lower of the last two readings is less than 140/90, you say they are normotensive. Other way around, you call them hypertensive. What sort of investigation do? You should do a quick urine dip as a point of care testing. If you're able to do, you should look at their fundus to find out the features of hypertensive retinopathy. You could do a baseline ECG. As Jahangir sir has said, it will seldom give you any valuable information, yet you need to do that. And some lab investigations would include hemoglobin, glucose, creatinine, eGFR, electrolytes, lipid profile, those kind of things. Now, what is your target blood pressure? If you are in a primary care setting, that means you are seeing your general practitioner, your family doctor, they are treating your blood pressure. Their target could be less than 160/100. However, in the secondary care, you are seeing a patient in a pre-op assessment clinic. That's a secondary care. In a secondary care, you could allow a slightly higher target. That could be less than 180/110. That doesn't mean your target is 178/108. That just means you will have a bit of greater flexibility. If in the secondary care, your blood pressure is more than 140/90, but less than 140/110, you shouldn't postpone a routine operation, elective operation, okay? You should inform their family doctor, their general physician, or their heart doctor, or whoever, that their blood pressure tends to be a bit high, so they need to do something with that. But anyone having a blood pressure more than 140/90, but less than 180/110, they need something doing around it, but that doesn't mean you should postpone their elective operation. So whatever time you have got, you need to try and do something with that to control their blood pressure a bit better. Now, how do you do that to have optimized outcome? So there are a few steps, there are a few very simple steps you should remember in managing someone's blood pressure. If someone is less than 55 years old, the agent of choice is either an ACE inhibitor or a angiotensin receptor blocker. Make sure you don't combine them. If they are more than 55 years old, you rather use a calcium channel blocker. In some elderly patients, calcium channel blocker will not be tolerated very well. In some cases, there will be evidence of heart failure or high risk of heart failure. In those cases, you could use a thiazide-like diuretic rather than a calcium channel blocker. Thiazide-like diuretic means that's not a classical bendroflumethiazide or hydrochlorothiazide. That's a modified kind of thiazide-like diuretic. The classical example is indapamide. You could give 1.5 milligram modified release once a day. But if their blood pressure, if they're already on a bendroflumethiazide or hydrochlorothiazide and their blood pressure is well controlled on that, don't change that. That's fine. So the bottom line is, they are less than 55, give ACE inhibitor or ARB. More than 55, give a calcium channel blocker or a thiazide-like diuretic if they are at risk of heart failure. Now, step 2. Many of the patients will not have blood pressure optimizedly controlled with step 1. In that case, it's very simple. You just add up the other group. If they were already on ACE inhibitor or ARB, you just add up calcium channel blocker. If they were already on calcium channel blocker, you just add up ACE inhibitor or ARB. Again, if you're adding up calcium channel blocker, you need to see if they have high risk of heart failure or already on heart failure. If they have got high risk of heart failure or they are already on heart failure, you give
diuretic, a thiazide-like diuretic, rather than a calcium channel blocker. In step 3, you just combine all these 3 things together. Calcium channel blocker, ACE inhibitor or ARB with a thiazide-like diuretic. So very simple. Step 1, 1 agent. Step 2, 2 agent. Step 3, 3 agents. Step 4 will be possibly be 4 agents. Let's see. So if you are at step 4, make sure you have reviewed these step 3 drugs. Make sure that they are at their optimal doses. See if you have any opportunity to increase your dose. If not, then they are possibly resistantly hypertensive. In those cases, you could potentially try a potassium sparing diuretic like spironolactone, 25 milligram once a day, given their potassium is normal. If their potassium is a bit high, then you shouldn't try spironolactone. Rather, you should try thiazide, more increased doses of thiazide if possible. If more diuretics are not an option, then you use either an alpha blocker or a beta blocker. So some of the students might be a bit surprised why we are so conservative about beta blocker or alpha blocker. So many will remember about, even when we were postgraduate students, there were loads of newer studies came up about the novel effects of beta blocker, trials like POES and things. So now we know that some of those data were a bit dodgy, and all those studies have been thrown away now. And now we know beta blockers in long term are not really the best agent to manage blood pressure, unless they have got other reasons to have beta blocker, of course. So if their blood pressure is even uncontrolled with 4 drugs, ACE inhibitor, ARB, calcium channel blocker, diuretic, alpha or beta blocker, then you use expert help. When can you cancel an elective surgery? This is a very common question we are asked on our day-to-day basis, can easily be asked in exam as well. So the AAGBI, so Association of Anaesthetists of Great Britain and Ireland guideline says, cancellation of elective operation with a blood pressure of less than 180 over 110 is not appropriate. Okay? If their blood pressure is 180 over 110 or more, you could potentially cancel or postpone an elective operation. Now, decision to cancel is not easy, you know, so always you need some expert help. And again, it should be multidisciplinary. It should be a multidisciplinary consensus when you really cancel a case. If you see someone's blood pressure is generally well controlled at home, and you are trying to attribute stress for their high blood pressure, then there is little benefit of delaying the operation. Okay, I'll give an example. For example, a patient having a carotid end arterectomy with a high blood pressure, more than 180 over 110. Will it be beneficial for him to delay the operation? They're already having TIA, so now if you delay it further, they will have a stroke. Of course, there is very high risk of having an intraoperative cerebrovascular event, but delaying the operation will possibly not be helpful anyway. On the other hand, if you're doing a cancer surgery, I know cancer surgery is urgent, you have to do it as soon as possible, but taking the whole picture into consideration, if you have a high blood pressure and you want to take a couple of more weeks to optimize that, and you want to postpone the cancer surgery for 1 to 2 weeks, this will possibly be at the best interest of the patient. Okay? You can possibly postpone. About beta blocker, we have to elaborate a bit. So beta blocker, as we said, is not a preferred initial agent unless you are in certain conditions. For example, in some young people who cannot really tolerate ACE inhibitors, particularly women with childbearing potential. So ACE inhibitor and ARB are more or less contraindicated in any phase of pregnancy, even in any lady with a childbearing potential. So you don't have to give that. So you could consider beta blocker. Or people with a baseline increased sympathetic drive, you could give that. If you have initiated a beta blocker as their antihypertensive, you should consider using if they need a second antihypertensive, you should always consider using a calcium channel blocker. The reason one of the main reasons we don't want to use beta blocker long-term as antihypertensive is risk of developing diabetes in the long run. However, let's not misunderstand a basic concept. If someone has to take beta blocker for their ischemic heart disease, they have to take it. So we are talking about beta blocker as antihypertensive, not as anti-ischemic or anti-arrhythmic property. Now, beta blocker in perioperative period, all of us know withdrawal of beta blocker in the postoperative period is associated with serious outcome. You have a increased chance of non-ST elevation MI or type 2 MI. Okay, so beta blocker should not be withdrawn before surgery, and should, if they're already on beta blocker, it should not be withdrawn before surgery and should be restarted as soon as possible after surgery. RAS pathway, I'm not going to elaborate. So RAS has got another pathway linked to that we kind of recently discovered. We are not going to elaborate all these, but ACE inhibitor and ARB. So these are very useful agents as we have seen. So ACE inhibitor and ARB, why are they so precious? Because they can improve the overall outcome of all sorts of cardiometabolic diseases. Okay, so it's really valuable in the perioperative period. Now, what do we do with ACE inhibitor and ARB in the perioperative period? So there are two schools, as we know, about continuing or stopping ACE inhibitor or ARB in the perioperative period. If you are asked a question in your exam, how do you modify ACE inhibitor or ARB in the perioperative period? What I would answer is, first of all, there is no universal guideline. There are some points that favor continuing, and there are some points that favor stopping. For example, if you stop ACE inhibitor ARB in the perioperative period, you will have less hypotension, less organ hypoperfusion. That will possibly be beneficial in operation with major fluid shift or major blood loss. There are some points which favor continuation of ACE inhibitor. For example, in heart failure patient, all of us know ACE inhibitor delay remodeling of heart, so prevent decompensation of heart failure. So it will also be useful in resistant hypertensive patients, and it gives a significant renal protection. So there is significant amount of data these days which claim that ACE inhibitor and ARB has got renal protective effects. So what do you do at the end? So as I say, there is no universal guideline. The guidelines on the other side of Atlantic significantly differ from Europe. So the US guidelines say continuation of ACE inhibitor is reasonable in any patient, irrespective of the indication of ACE inhibitor ARB. Whether you give it as antihypertensive, whether you give it for heart failure, whether you give it for renal protection, you can continue it. However, if you stopped it, you should restart it as soon as possible. The European guidelines are slightly more conservative. They think if you are giving ACE inhibitor and ARB for heart failure or LV dysfunction, you should possibly continue it. But if you are giving it as purely as antihypertensive, you could consider discontinuing them transiently. That's the European guideline. Finally, what is your final answer? The final answer is perioperative ACE inhibitor and ARB therapy needs careful consideration, and decision needs to be made on case-to-case basis. Intraoperative care is very simple. I mean, it's a very basic concept. If you have any absolute or relative hypotension in the perioperative period, your overall outcome will be adverse. So you better try to maintain a sort of cardiovascular stability. You try to avoid instability in the perioperative period. There is evidence that if you have significant hypo and hypertension in the intraoperative period, you will have adverse outcome. Postoperatively, again simple. If you have too much of high blood pressure, you will have bleeding risk. If you have too much of low blood pressure, you will have organ hypoperfusion risk, and that is possibly somewhat related to type 2 myocardial infarction and possibly to stroke as well. So about type 1 and type 2 myocardial infarction, if we have another opportunity another day, we'll discuss those bits of cardiovascular system. But significant hypotension in the postoperative period is never good. So restarting of antihypertensive medications should be dealt with carefully whenever appropriate clinically. If your blood pressure is more than 140 over 90, of course, you refer your patient to their general practitioner or their medicine doctor, whoever. So all these things are based on the guidelines from Association of Anaesthetists of Great Britain, Ireland, and British Hypertensive Society. I'm sure there are loads of other guidelines, but of course, we follow these guidelines. So I based all the discussions on these. So if anyone has got any different guideline and want to refer to that, that's perfectly all right. Now, to finish off today's discussion, Bunna, are you there?
Yeah, I'm here.
Bunna, do we have 2-3 more minutes?
Yeah, sure. Absolutely.
Great. So for students, I want to give you some assignment to do at home. Okay. So Bunna, you could potentially share it in your group. Okay. So I'll be giving out some slides. So these slides will have some questions. Okay. So these are some practice questions. This can be this can be freely shared among the FCPS and MD finalist students, and this can be. So what we can do, we share these slides. So these slides will have questions, and any students who is enthusiastic enough can try to solve these questions and put them, put the answer in the comment section, okay? And then after some time, we gather all the answers and try to find out who has given the most correct answer. And then we could potentially discuss the most correct answer after that. Could you do that, Bunna?
Yes.
Could you,
yeah, sure. That would be amazing. I mean, this is brilliant. Since we have the examinations coming, it will be quite helpful.
Amazing. So let's try do that then.
Yeah.
Okay, screen share. Can you see the slides now?
Assessment and optimization practice CRQs. Yes, we can.
Great. So I'll just very quickly go through this. So as I said, these will be shared freely in the Facebook group. So you will have a chance to look at this properly. And then, so what the MD and FCPS finalist, I mean, you don't have to be a finalist student, you just have to be a student to answer this. Any practicing anesthetist can also answer if they fancy up. So anyone can answer basically, but the target population is final students.
So we are not quite familiar with CRQs already, but we do have some SAQ changes coming up, and could those be the same kind of questions? I mean, we do have SAQs that have shortened in basic forms, but we are not quite familiar with CRQs yet.
That's all right. Let's forget the term CRQ or SAQ. Let's just take them as questions for final FCPS or final M.
Thank you so much.
Let's just forget or ignore the terminology for a minute. Okay. So these are basically short answer to a short question. So the first question is management of severe asthma in, of course, so everything we're discussing today is perioperative care management. So management of severe asthma in the perioperative period, that was compounded by a critical incident. I mean, complicated by a critical incident. So the first question related to that is, list 3 possible pathophysiological changes in the lungs seen in asthma. In asthma, there will be many pathophysiological changes. You need to enumerate main 3 of those. So this is your kind of basic knowledge testing. So this is from your part 1 knowledge, essentially. Then you are given a clinical scenario. So you've got a 57-year-old female who have known asthma, having a laparoscopic cholecystectomy under general anesthetic, of course with endotracheal intubation. So now you're given some patient data, patient parameters. Their weight is 62 kg, their height is, their age is 57, weight is 62 kg, height is 165 centimeter. And then they have given their FEV1, FVC, their spirometry results basically. Now, you have to interpret her preoperative pulmonary function test. Okay, so interpret the pulmonary function test and write down in here. Then the next part of the question, list 6 factors that may cause her to develop bronchospasm during GA. There are many factors, you know, whenever you are asked factors, you should broaden your mind. The factors could be patient factors, surgical factors, anesthetic factors. You always classify them. Then you can find out more and more options to put in your answer sheet. So not like you could write down 2 patient factors, 2 surgical factors, and 2 anesthetic factors, and that should answer your question. Or you can just find out any 6 factors that you think most important. Then she does develop acute severe bronchospasm during the anesthetic, of course. What are the drugs, including dosage, if you could, can be used to treat this? So you've got intraoperative bronchospasm. What are the options of the drugs with dosage? You need to write them down. Then list 4 other actions you would take in the early management of this emergency. So you will of course give drugs, but there will be other 4 options. There will be other 4 actions that you would take early. So you need to, when you appear in your final exam, you need to be very alert on some word that you need to emphasize on.
early management of this emergency. Okay? Call for help, never forget. Given a clue. Second and last question, cardiomyopathy. Okay, today is World Heart Day, so we'll finish off with a question on cardiomyopathy. So there is a 56-year-old man listed for elective repair of large incisional hernia. He has a background history of dilated cardiomyopathy. Now, you're given a list, types of cardiomyopathy. Okay, so you know the WHO recognized types of cardiomyopathy is dilated, hypertrophic, restrictive. You're given a table. Now you need to fill out this table. Okay, cardiac output, stroke volume, and contractility of the heart. These are the three variables. Okay, you need to say what happens to each variable in each type of cardiomyopathy. Say, for example, they have given some, like in your dilated cardiomyopathy, cardiac output falls. In your hypertrophic cardiomyopathy, stroke volume falls. In restrictive cardiomyopathy, contractility remains normal. You need to fill out the other boxes. Now, the next question, although most commonly it's idiopathic, there are other causes of DCM, dilated cardiomyopathy. What are the other three main causes of DCM? Again, this is from your basic knowledge. Now, your practical thing. At the preoperative clinic, the patient's symptoms of heart failure appear to be well controlled. So they are compensated, not decompensated. Chest is clear. He takes ACE inhibitor, Ramipril, 10 milligram a day. And last attended cardiology clinic more than 12 months ago. Now you need to list 3 investigations you would request prior to listing him for elective procedure. 1, 2, 3. 3 investigation you need to write down. 3 most relevant and most important investigation. So you've done the investigations now, and then you are going for the operation now. So aside from the AAGBI, I mean, our Association of Anaesthetists of Great Britain and Ireland, they have got a recommended set standard monitoring. Aside from those, what further monitoring and access would you instigate prior to anesthetizing him for his incisional hernia repair? What other monitoring you will do basically? What other advanced monitoring you would do intraoperatively? Then state the principle by which you manage his cardiovascular physiology. So you know the basic principle of managing cardiovascular physiology intraoperatively. Finally, your consultant suggests you do an epidural for the patient. Okay. Now you are a bit unsure. You are trying to find out what are the advantages and disadvantages of doing a central neuroaxial block. So write down at least 2 advantages and 1 disadvantage of doing an epidural for this patient with DCM. Is it okay? So these are just model questions. So as I said, forget the type of question. Okay. So you can easily be given this kind of question in your exam. So it will be a very good practice for the final student. And since, as I understand, because of the pandemic, face-to-face teaching is very limited. So most of the teaching is online. So our practice should also be online, I think. So Bonna will make a mechanism of sharing these questions in appropriate media, and then students can try and put some answer in the comment box or somehow somewhere, and then we can find out can we do one thing? Is Nimmi there?
Yeah.
Nimmi?
Yes, I am here.
So is Aftab also there? Is Aftab joining by any chance?
Yes.
Yes, I think.
After, can you just please unmute yourself?
Hello, Aftab.
I'm sure.
Yes.
Hi. So, একটা কাজ করা যাক, নিম্মি আর আফতাবকে একটা দায়িত্ব দেই জয়েন্টলি। যদি হচ্ছে দুইজনের কোনো আপত্তি না থাকে, তো নিম্মি আর আফতাব দুইজন মিলে যে আনসার গুলো জমা পড়বে আমাদের সেই একটা ফেসবুক গ্রুপে আমরা এই দুইটা কোয়েশ্চেন আমরা পোস্ট করব। যে আনসার গুলি জমা পড়বে ওই আনসার গুলি নিম্মি এবং আফতাব চেক করবে। চেক করে এর মোস্ট অ্যাপ্রোপ্রিয়েট পসিবল মোস্ট অ্যাপ্রোপ্রিয়েট আনসার নিম্মি এবং আফতাবের কাছে থাকবে, এবং তারপর ওরা চেষ্টা করবে যে সবচেয়ে ভালো আনসার কে দিয়েছে, তো তাকে আমরা একটা স্টার অফ দ্য উইক একটা অ্যাওয়ার্ড দেব। এটা কি করা যায়? আমার মনে হয় যে একটা নিম্মি কি বলো, করা যেতে পারে এটা?
এটা করা যাবে, and it's a very good idea.
আচ্ছা, আফতাব
ইন্টারেস্ট গ্রো করার জন্য।
একটা সমস্যা নাই।
হ্যাঁ, অবশ্যই করা যাবে, অবশ্যই।
আমার মনে হয় তাহলে আমরা একটা মেকানিজম বের করব। যেহেতু বন্যা এই গ্রুপের অ্যাডমিনিস্ট্রেটর, বন্যা শুডন্ট পার্টিসিপেট ইন ইট, শি উইল হ্যাভ কনফ্লিক্ট অফ ইন্টারেস্ট ইন ইট। সো নিম্মি এবং আফতাব কারেক্ট আনসার গুলি কালেক্ট করবে এবং ওদের কাছে আনসার থাকবে। ওরা হচ্ছে বেস্ট আনসার খুঁজে বের করে দুইটা কোয়েশ্চেনের জন্য দুইজন স্টার অফ দ্য উইক নির্বাচন করবে, এবং সেটা তাদেরকে আমরা সেলিব্রেট করব পরের উইকে, ইফ দ্যাট ইজ পসিবল। বন্যা,
That would be an absolutely great idea. I'm very unfortunate to not be a part of it, but I encourage my other colleagues and examinees to participate in it interactively, and send your answers to Dr. Nimyapu and Aftab Bhai, so that we would select our star of the week.
Great. That's very kind of you. So now I will pass it on to Bonna to finish it off with the permission of our respected teachers.
So I don't think I have enough words to thank you for this excellent talk, entirely based on the examination, and we know that we need it since the systems are changing quite extensively, and I'm very happy to have been a part of it. And we are quite late already into the night, so if anybody else doesn't have anything to add, I would ask Lutful Aditya to give his comment on the session, and then after the next phase of actions, we can conclude the session for this day. Sir?
হ্যাঁ, পলাশ, তুমি স্ক্রিন শেয়ারিংটা বন্ধ করে দাও।
শেয়ার হচ্ছে, সরি।
It's fine.
কেমন করে হচ্ছে? কেমন করে বন্ধ করব?
Stop screen sharing দিলেই এটা বন্ধ হয়ে যাবে। আমি এখান থেকে করে দিচ্ছি।
Okay. Thank you, Palash. It was a wonderful session. Her first part was fantastic, jeta Iqbal sir ebong Jahangir bhai boleche. Second part was very good for the students, ebong I hope the students এটাতে eagerly participate করে, তাহলে আমরা এটা আবার পরবর্তীতে কন্টিনিউ করব ইনশাআল্লাহ। এখানে আমি জাস্ট একটু আরেকটা জিনিস আমি সব সময় দেখছি, একটা জিনিস আমাদের বিভিন্ন লেকচারে বিভিন্ন সময় চলে আসে, ইরাস, এনহ্যান্স রিকভারি আফটার অ্যানেস্থেসিয়া, আফটার সার্জারি। এই জিনিসটা নিয়ে আমরা অনেক লেকচারে অনেক ছোট ছোট ভাবে অনেকগুলো কথা শুনেছি। আমার একটা পুরো কনফারেন্স করার অভিজ্ঞতা আছে ইরাসের উপরে। আমি মনে করি ইরাস is very important for us, not only us anesthetists, it is also very important for the surgeons also. আমাদের এখানে সার্জনরা ইরাস সম্বন্ধে কোনো আইডিয়াই নাই এবং তাদের সাপোর্ট আমরা কখনোই পাই না। এই জন্য ইরাসটা আমরা চাইলেও করতে পারি না অনেক সময়। তো আমি একটা চেষ্টা করতে চাই যে আমি একটা ইরাস নিয়ে, শুধুমাত্র ইরাস নিয়ে একটা প্রোগ্রাম করতে চাই যেখানে সার্জন এবং অ্যানেস্থেটিস্ট উভয় গ্রুপ থাকবে। এরকম একটা করলে কেমন হয়? তুমি পলাশ, কি তুমি একটা, আমি অ্যারেঞ্জ করব, তুমি কি একটা লেকচার দিবে ইরাসের উপরে পুরো?
Great idea, sir. Of course, anytime.
ঠিক আছে, তাহলে আমি এটা লেট মি অ্যারেঞ্জ, ইট উইল টেক সাম টাইম। আমার সার্জন কলিগদের এবং অ্যানেস্থেটিস্টদের নিয়ে আমি এটা করবো। দিস ইজ ওয়ান অফ মাই ফেভারিট টপিক, ইরাস। তো দেখা যাক ইনশাআল্লাহ যদি পারি। আর আমরা চেষ্টা করছি, ও যেটা বলেছে যে সিপ্যাট মেশিন, সিপেক্স মেশিনের জন্য আমরা খুব চেষ্টা করছি আমাদের এখানে। আমরা এখনো মেট এবং ডাসি স্কোরে আছি। তো আমরা যদি সিপেক্সটা কোনোভাবে জোগাড় করতে পারি আমাদের এভারকেয়ারে, তাহলে হয়তো আমরা সিপেক্সে চলে যাব খুব শিগগিরই ইনশাআল্লাহ। তো থ্যাংক ইউ পলাশ।